Hello, my name is Rhea Morani, and I'm here with Ritu Shah today, and we will be presenting the double-edged sword effect of cancer therapy, second malignant neoplasms in pediatric cancer survivors. We have no relevant disclosures. Cancer is the second most common cause of death among children aged 1 to 14 years old in the United States. As shown in the graph over here, pediatric cancer-related mortality rates have significantly improved over the last 2 decades. However, as a result, there has been an increase in therapy-related complications, including second malignant neoplasms. Second malignant neoplasms are responsible for nearly half of non-relapse deaths among long-term survivors and are a major source of morbidity even after 20 years of therapy. So, what exactly is a second malignant neoplasm, or SMN? SMN refers to a histologically different primary cancer that occurs at least 2 months after the end of treatment of the prior cancer. Childhood cancer survivors are at a 4 to 6-fold increased risk of developing a new cancer as compared to the general population. As shown in the graph here, to the right, even decades after treatment of the prior cancer, the risk of developing an SMN still steadily increases, showing the gravity of the situation. Now, we will discuss the risk factors for developing SMNs in a general population. These can be therapy-related, which include chemotherapy, radiation, and stem cell transplant. They can also be patient characteristics, including genetic predisposition and age, or environmental or behavioral factors. Specifically focusing on leukemia, the most common type of cancer in the pediatric population, the treatment used often includes alkylating agents, radiation, and stem cell transplantation to improve chances of cure, but it also elevates the chances of developing SMNs in pediatric leukemia survivors. In the next few minutes, we will be talking about the different risk factors which can induce SMNs more in depth. Our first category is chemotherapy-inducing SMNs. The common culprit for these types are alkylating agents, which hold a dose-dependent risk, and topoisomerase II inhibitors, which hold a dose-schedule dependent risk and have a unique cytogenic 11q23 translocation. Those receiving chemotherapy have an increased relative risk of developing SMNs by 1.4 to 2.2 folds as compared to the general population, and those with chemotherapy-induced SMNs have an increased risk of developing therapy-related acute myeloid leukemia, or therapy-related AML, as well as thyroid cancer, as compared to other risk factors for SMNs. For example, on the left, we have an MRI scan of an 18-year-old patient with left nasal Ewing sarcoma. He was treated with 6 cycles of chemotherapy, which was able to resolve the Ewing sarcoma. 4 years later, the patient presented with high white blood cell counts, which led to further bone marrow analysis. This revealed increased blast cell count by 84%, and these blast cells can also be seen on the bone marrow smear on the right. This turned out to be therapy-related AML and SMN in his situation. Despite aggressive chemotherapy and stem cell transplantation, the AML relapsed and the patient unfortunately succumbed to fungal pneumonia. In the previous case, we saw an example of how alkylating agents and chemotherapy can lead to therapy-related AML. And now we're going to see how they can also increase the chance of developing thyroid cancer. The scan on the left shows a 13-year-old patient's right iliac Ewing sarcoma. They were treated over the course of 1 year with surgery as well as neoadjuvant chemotherapy. During a follow-up, a heterogeneity was spotted in the patient's left thyroid lobe. After an ultrasound for further investigation, this turned out to be a colloid cyst in the left thyroid lobe, and there was a mass in the right thyroid, which is indicated with the pink arrow in the bottom right corner. This was suspicious due to its vascularity, which can be seen in the ultrasound because it is colored. This ended up being a papillary carcinoma, an SMN in the patient's case, in the right thyroid, which had to be removed with a right thyroidectomy. There's another example here. In 2013, an 11-year-old boy presented with splenomegaly due to acute lymphocytic leukemia. This was treated with chemotherapy and the patient achieved a complete response. In 2015, the patient relapsed with acute lymphoblastic leukemia with CNS involvement. Once again, he received intensive chemotherapy and was able to achieve a complete response. Later, in 2021, the patient presented with pancytopenia, leading to bone marrow analysis, which revealed an 87% increase in blast cells. Cytogenetics showed translocation 1119, characteristic for therapy-related AML, which the patient was later diagnosed with. Now, we will move on to talk about radiation-induced SMNs. Ionizing radiation is often used for Hodgkin's lymphoma, CNS cancers, solid tumors, or it can also be used as a preconditioning regimen for stem cell treatment. Radiation causes increased risk for non-melanoma skin cancer, breast cancer, thyroid cancer, sarcomas, bone tumors, as well as benign CNS tumors. Radiotherapy is the strongest independent risk factor with a relative risk of 2.7 times more likely to develop an SMN as compared to patients not receiving radiotherapy. The SMNs that do occur often do so after a latency period of 5 to 10 years. There is a well-known increased risk of breast and thyroid cancer in patients with Hodgkin's lymphoma treated with mantle radiation, particularly for doses greater than 35 Gray. This patient had a history of Hodgkin's lymphoma at 16 years old and was treated with mantle radiation. At 52, she had an ultrasound for a palpable breast nodule, which ended up being triple-negative breast cancer that likely developed due to the radiation treatment from decades prior. Prophylactic craniospinal radiation increases the risk of developing CNS tumors, endocrinopathies, and has deleterious effects on cognitive development. However, its use is decreasing with more CNS penetrative therapies and intrathecal therapies. This patient was treated with chemotherapy and craniospinal radiation for ALL at the age of 8. At 45, she was investigated for cognitive decline. An MRI revealed radiation-induced meningioma, which can be seen on the right, and cavernous malformation, which can be seen on the left, in the left occipital lobe. Multiple basal cell carcinoma and nevi were also found in the back and her scalp. Thank you for your attention, and now I will be turning to Dr. Shah to continue the rest of the presentation.
Thank you, Rhea. My name is Ritu Shah, and I'll be going through the rest of this presentation. This patient is an excellent example of radiotherapy-induced SMN. He was treated with radiation for left iliac bone Ewing sarcoma in 2016. Here we see the enhancing lesion on MRI. A year later, imaging showed complete resolution of the mass. And a few years down the road, PET-MR showed an enhancing mass that was initially thought to be recurrence, but was later proven to be a radiation-induced spindle cell sarcoma. Another example we saw was of this child. He was treated with posterior intracranial radiation as a part of his treatment for medulloblastoma as an infant. Now, 4 years later, he presented with a painful, progressively enlarging swelling at the back of his head. Later, this was proven to be a case of radiation-induced skull osteosarcoma. Another very important risk factor is hematopoietic stem cell transplantation. A whopping 7% of stem cell transplant recipients have SMNs within 20 years post-transplant, and this risk is 60-fold if the child is younger than 10 at transplantation. This patient, for example, received a stem cell transplant in 2010 for ALL. You can see the splenomegaly depicted in this image. 2 years later, the patient presented with seizures. Imaging shows a progressive contrast-enhancing mass in the right occipital lobe of the brain with overlying dural enhancement and involvement. Following surgical resection, this mass was found to be diffuse large B-cell lymphoma. Hereditary mutations are also a risk factor for second neoplasms. Mutations in many genes like the TP53, the RB1, and the BRCA gene have been implicated. The cumulative probability of developing a second cancer in patients with TP53 mutations is estimated to be 57% within 30 years following the first cancer diagnosis. Take, for instance, this patient with a TP53 mutation. She had multicentric breast cancer seen on ultrasound and a right humeral pleomorphic sarcoma seen on MRI. Another patient with a TP53 mutation had alveolar rhabdomyosarcoma of the left arm, which was treated with surgery and chemotherapy, eventually needing left upper extremity 4-quarter amputation. 20 years later, the patient developed an enlarging lump in the right breast, which was seen as hypoechoic mass on ultrasound. MRI showed bilateral breast masses, which were proven to be a right breast phyllodes tumor and a left breast triple-negative breast cancer. Mutations in the RB1 gene can also increase the risk of SMNs, with increased risk persisting for 30 to 40 years following retinoblastoma treatment. This image shows a sinonasal sarcoma in a 19-year-old boy who was previously treated for bilateral retinoblastomas at the age of 2 years. How can we mitigate the risk of these second neoplasms? We can do this through chemotherapy modifications like reducing the cumulative dose of alkylating agents or adjusting the dosing schedule of topoisomerase II inhibitors. We can do it by alternating therapies. This reduces the risk by reducing exposure to a single class of carcinogenic drugs. We can also do this with radiation adjustments like lower radiation doses and using more precise delivery techniques like IMRT. And we can do this by advancing radiation delivery. For example, using approaches like proton therapy that deliver radiation directly to the tumor. Surveillance or screening is important as early detection can help reduce morbidity due to SMNs. Both current and future providers should be familiar with the surveillance recommendations and educate their patients accordingly. And this patient education is a major factor in adherence to screening guidelines. Pediatric oncologists should also implement structured transition programs. This brings us to our conclusion. Cancer survivors are prone to second unrelated cancers due to therapy, genetic, and environmental factors, which can occur even decades later. But personalized therapy and proper transition of care with lifelong surveillance can help improve survival. These are our references. Thank you so much for your time and